Good morning, everybody. As always, giving it a moment for everybody to join into this week's Medical Grand Rounds. This is our third week in a continuing series of health advocacy, public awareness, and we really have yet again another important topic and presenters we're excited to hear from. We want to maximize as much time as possible, hopefully get to any potential questions later in the hour. So I want to get into our updates, and we really have just one update this week. Our updates regarding COVID, there really aren't too many, except for I'm hearing from Dr. Bowman that we are starting to see a decrease in number of cases. So hopefully that's an ongoing trend. We'll continue to update more in the coming weeks on that. But this week we do have Dr. Jorge Salinas. He's the co-medical director at Stanford of Infection Prevention and Control Program. And he has been updating a lot of our leadership about monkeypox. We wanted to give some brief updates to follow what Dr. Pinsky mentioned last week regarding monkeypox. So Dr. Salinas, thanks so much for being with us. I'm going to turn it over to you.
Thank you so much. I'll share some quick slides. I'll try to give a brief summary of monkeypox treatment, especially antivirals, over the next 3 minutes. There are no FDA-approved antivirals specific for monkeypox. However, some treatment options include tecovirimat, that is licensed for the treatment of smallpox, vaccinia immunoglobulin, again for vaccinia infection, cidofovir and brincidofovir. That all of these drugs could possibly be used under expanded access investigational new drug protocols, EA-IND. However, as you can imagine, that requires an informed consent and a research protocol with several visits, labs, etc. The main drug being used during the current monkeypox outbreak is tecovirimat, also known as TPOXX or ST246, which is an antiviral developed to treat smallpox. There are two versions of it, oral or IV. They are only available through the Strategic National Stockpile, and the approved indication is for treatment of smallpox. However, CDC holds an expanded access investigational new drug protocol for non-variola orthopox infections, including monkeypox. As of July 22, 233 people have started this treatment in the United States, including 7 people here at Stanford. Fortunately, this drug is well tolerated with mild side effects, including headache and nausea. However, may increase the levels of some medications that may reduce glucose levels. So that's something to keep in mind. This drug, tecovirimat, works by targeting the VP37 protein of orthopox viruses, which is a protein that is required for virus maturation and release of the virus from infected cells. The treatment indications include severe disease, sepsis, multiple confluent lesions, or lesions that are present in sites with risk of stricture, proctitis, urethritis, eye disease, pharyngitis. Another treatment indication is evidence of illness complications, or if the patient is hospitalized, and also in patients that have risk for severe disease, immune compromising conditions, young age, pregnancy, breastfeeding, other diseases that have a risk of stricture or fistulas, and then significant active exfoliative dermatologic conditions. How to treat somebody at Stanford? Again, because this treatment is only given through the EA-IND, only a small group of providers can prescribe this medication. So for most cases, an urgent referral to the ID clinic would be indicated. Place an urgent referral to the Hoover ID clinic. Enter monkeypox in the recent field. Patients will be seen first virtually by an ID provider within 24 to 48 hours. However, if the patient is hospitalized or is an emergency in the emergency department, you can page the inpatient ID consult team for these reasons as well. If you have questions about treatment, we have a pager number 15773 for treatment questions. The protocol nowadays, since Friday, has been simplified in the sense that only 3 encounters are required, 1 for enrollment and 2 follow-up visits that can be done through telehealth. one during treatment, and one 7 to 10 days after treatment completion. I'll finalize by saying that because there is paperwork and this comes through the national stockpile, the supply is limited. However, there is a movement towards starting to treat people earlier, if possible. But again, the limitations are the paperwork and the supply availability. But in theory, we would want to start people on treatment earlier in their disease course. Thank you.
Dr. Salinas, thank you so much for that update. And if anybody has any questions, please put it in the Q&A. We can address it. And of course, as there are more updates, Dr. Salinas and colleagues, please always welcome to come back and provide those updates to our community. So thanks again. I next want to quickly move over and just mention next week's ground round speaker. A lot of our faculty actually hanging out with us right now, Dr. Salas and Drs. Dunn. Were very instrumental in setting up next week's ground speaker. So please let me know if you'd like to make any comments. I do want to mention that this is our first in-person medical grand rounds we've had in a while. And even more importantly, one of our first medical grand rounds of a presenter coming from remote, so not from Stanford, to come and present. So we're really hoping and excited to have a lot of people come in person. We'll always have the online version as well for next week. It's going to be Dr. McCullough West. She's going to be talking about the topic transforming healthcare. And again, Dr. Salas or Dunn, if you have any comments, please welcome to say anything. But thank you so much for helping organize this really important topic next week, and really excited to have Dr. West come and join us in person next week and meet a lot of people here.
Thanks so much, Dr. Osdalga. I just wanted to add one thing, which is just so people know, because her title is somewhat ambiguous. She's going to be talking about transgender healthcare. So that's the topic of the talk next week. And I really look forward to seeing folks there in person in LKSC. It's in LKSC, right?
Yes. Yeah, our usual place in LKSC. We'll send more emails and updates on those details, and we'll have breakfast as well. So come join us in person. And then, so this week we have, as I was mentioning, a third week of series of public health advocacy. We have presenting today, Dr. Julie Parsnet, who will be leading this conversation and hosting and providing some introductory remarks. She'll be introducing both Dr. Amy Barnhorst, the Vice Chair of Community Mental Health, and running a program called Bullet Point she'll talk more about, as well as Professor David Studdert, who's been on grand rounds with us before. He's the co-medical director. He's the acting vice provost for research for Stanford University. But I do want to briefly say a few things about Dr. Parsnet. She's our chief of infectious diseases and she's in a history of being our chief. She's currently the George DeForest Barnett Professor of Medicine and Professor of Epidemiology and Population Health. She's a past chief of our Department of Medicine in the Division of Infectious Diseases. And I do want to give a shout out to Dr. Parsnet. Many of you who've been following grand rounds, particularly since we started doing this online version, we had Dr. Parsnet come and speak in April of 2021 to talk about herd immunity as our epidemiologist. She actually was one of the first, as far as I'm aware, the first person to go out there and say that COVID would not go away quickly, and herd immunity was something we're not likely going to see. And if you Google her name, and you'll see she was in a lot of articles back in April and May. She was exactly right. And I always give Dr. Parsnet credit for really predicting essentially what has been happening with COVID over the last year or 2 years. So thanks so much for all the support you've done. But Dr. Parsnet is not just only in infectious disease. She's very passionate about gun control. She's the president and board chair for SAFE. It stands for Scrubs Against Addressing the Firearm Epidemic. It's a 501(c) that has over 50 chapters across the country in medical schools working to teach healthcare providers about firearm injury prevention and to increase firearm injury research and to advocate for evidence-based policies. SAFE was started 5 years ago by our own Dr. Dean Winslow, along with a Stanford medical student, Sarah Beth Spitzer, who's now a trauma resident and gun researcher at Harvard, along with many others. She's on the National Academy of Medicine's Gun Violence Prevention Task Force. Dr. Parsnet is also the board liaison to Doctors for America's Gun Violence Prevention Program, and she's on the SAFE Foundation board created by Mayor Sam Liccardo that hopes to direct resources towards gun resources and injuries and deaths in San Jose. So Dr. Parsnet, I'm going to turn over to you to introduce our other speakers. Thanks for doing everything you've done within gun violence and for being with us here today.
Thanks so much, Errol. And I'm going to just share my screen here. Here we go. And I'm actually, first of all, I want to just say that I don't think of myself as somebody who supports gun control. What I really support is reducing gun violence and gun injuries, firearms injuries and deaths. And that's where we're going to talk about today, is how, from a public health perspective, you might want to reduce firearms injuries and deaths and how physicians can help. I'm just going to introduce the topic today, and I'm going to really let our guests do the crux of the speaking, but I just wanted to give some background information. So guns are very common in the United States. This is an old slide, actually from old, meaning 5 years ago, when 33.5% of households in the United States, predominantly rural households, but households in every state, had gun owners within those households. And that number, through the COVID surge over the last 2 years, the surge of gun purchasing has now risen to over 44%, somewhere in that range of households have guns. And there are more guns than there are people, with about 1.25 guns per American citizen. And the data on injuries are not very good, but the data on deaths are getting to be increasingly accurate. In 2020, there were 45,000 deaths from gun violence in the United States, which is about 124 people per day. And that was a 35% increase from the year before, which was another 35% increase from the year before that. So we're on a big surge of gun violence and injuries in the United States. 86% of the victims are male, and 87% of non-fatal firearms injuries are male. So this tends to be a disease or a problem that's more common in males. And if you look at the bottom, you could see that at the under the 39%, you could see that the increase in firearm homicides was more common among Blacks than among other groups. And in fact, Blacks continue especially to have much higher rates of firearms injuries and deaths than do whites, and particularly firearm homicide, many-fold more higher risk. In terms of injuries, 7 out of 10 firearms injuries are from firearm-related assaults, and 2 out of 10 are from unintentional firearms injuries. And you'll see that there are even though suicide is the leading cause of firearms death, those are usually fatal, and so they don't come into the emergency room as firearm injuries. Firearms injuries and deaths in the bottom right-hand corner. Homicides are more common in urban areas. Suicide is particularly in urban areas that are poor, and in counties that have high poverty levels. Suicides are more uniform across the country, and they occur in all population groups. They tend to occur more commonly in whites and older whites, whereas homicides tend to occur in younger adults. Oops, let me go back. And these are just the homicide and suicide rates over time. We actually had higher homicide and suicide rates back in the 1960s, or homicide rates, gun violence deaths back in the 1960s, and early 70s, but they plummeted in the 80s, 90s, and 2000s, and now are on a very rapid, steep rise. Homicides are in the blue here, and suicides are in black. And in general, and these are age adjusted, in general, suicides have represented about 2/3 of gun violence deaths. And but there's been a rapid big surge in homicides in the United States over the last few years. And now they're coming to be much more even in terms of the numbers per population. One of the things that has attracted the most attention of the public is this particular paper that came out in May of this year, and it's just a correspondence in the New England Journal, which showed that firearms injuries are now the leading cause of death in children in the United States, surpassing motor vehicle accidents. In the general population, firearms injuries surpassed motor vehicle accidents a number of years ago, but in children, this is the leading cause of death, leading children and adolescents, surpassing malignancies and drownings and every other cause of death in children. So this has attracted a lot of attention. And if you look at child deaths in the United States from gun violence, and you look at the comparable countries around the world, so the 12 wealthy countries around the world that are comparable to the United States, 98% of gun deaths in children are in the United States, with about 150 or less in all those other 11 countries, and over 4,500 or so in the United States. So we are quite different from everyone else. And that's shown here on this graph, where you could see how exceptional the United States is in this regard, where we're on that 5 right dot, and that's gun ownership on the x-axis, and gun deaths per 100,000, and the United States is clearly a standout in that regard. Despite that, there are still many in the United States who believe that the way to stop gun violence is to have more guns. And this was on the right is a very prominent book that was published in 1998 that advocated for really everybody to have guns, and that if we had more guns, we'd have less crime. And this is still touted by many people as the way that we should be going. So there are many people at Stanford who are doing firearms research, firearms injury prevention at Stanford, and I can't go through all of them, but just put up a number of them who I've been talking to about gun violence. But today we're going to be hearing from the second from the right at the top, Professor Studdert, who is going to speak to us today. He received his undergraduate and his law degrees with first-class honors at the University of Melbourne before going on to get his MPH and his doctorate in public health at Harvard. He was on the faculty at Harvard and then at the University of Melbourne before joining us here at Stanford as a full professor in 2013. And recently, Professor Studdert took on the role of vice provost for research, which is an enormous job. So I'm not sure how he's going to do everything he's doing now. It's just a huge job. Professor Studdert has done research in a wide variety of areas that are at the intersection of law and public health. And he's had some very prominent papers, including some very recently in the field of gun injuries. And so today he's going to talk to us about the health consequences of gun ownership. And he can also talk about some of the recent legal changes, but we're going to reserve those for the question and answer period today. So if you have any questions about that, he said he'd be happy to field them. So thank you very much. And Dr. Studdert, you're on.
Thanks, Julie. Let me share my screen here. I hope that worked. Can you see that okay? So thank you for the opportunity to join this group. And it's really nice actually to be able to give back to this series that's given me so much knowledge and insight especially over the last 2.5 years. So as Julie said, many Americans have access to guns. That access happens in 2 main ways. You own a gun, or someone you live with does, a spouse, a family member, a roommate. So how do we think about the totality of risks or of benefits associated with the gun? We could focus on the owner, but that's clearly too narrow. We could focus on the entire household. That's better, but it's important to remember that many, many millions of households with guns consist of a mix of gun owners and non-owners. So is it valuable to look specifically at those who live with gun owners but don't themselves own guns? We think so, and my group has been thinking a lot about that question over the last few years. We think it's important for several reasons. One reason is that this is a population that has been routinely overlooked in studies of gun violence, but it's a huge population. About 10% of American adults live in homes with guns but don't personally own them. The second reason why this population is interesting is that it's highly gendered. Most people who live with gun owners and don't own guns are women. And finally, it's interesting because it's kind of a classic public health concern. Individually, I can decide that it's desirable for me to install a swimming pool in my backyard. But if I have young children or nephews and nieces that like to visit, I should probably factor in the secondhand risks of drowning that my decision to get a pool creates. The best known risk or secondhand risk, I should say, in public health is, of course, environmental tobacco smoke. Tobacco law and policy was transformed in the 1970s and 1980s when we gained an understanding of the risks that smokers posed to people around them. So we wanted to bring a similar frame to bear on gun ownership, and that's what my group has been working on recently. At the same time, we wanted to allow for the possibility that, unlike smoking, it is possible that gun ownership can create secondhand benefits in certain situations. It may, for example, reduce the risks that people who live with gun owners will be hurt by assailants or intruders. So my team has published 2 studies in the last few months looking at the secondhand risks of gun ownership. The first looked at homicide, the second at suicide. I'm going to spend a few minutes this morning talking about a homicide study, and I'll start by describing the larger project that this study comes out of. The larger project is called Longshot, and it's a cohort study that our team has been working on here at Stanford since 2016. This is the team, and I want to recognize Yifan Zhang and Erin Holsinger from the Department of Health Policy here, and John Roden from Political Science, as well as our awesome collaborators from Northeastern, University of Pittsburgh, and UC Davis. We're following a large cohort of California residents. The cohort is built around California's dealer record of sale database, known as DROS. DROS captures information on lawful transfers of firearms in the state. DROS has operated for decades alongside state laws that require virtually every handgun transfer in California be transacted through a licensed dealer. Details of those transfers, including identifying information on purchases and weapons, are collected in this DROS database and permanently archived by the California Department of Justice. This is a really unique data resource for gun violence research, one of those only in California things. The data linkage we used to assemble the cohort has been described in earlier work. In summary, we linked individuals across 3 data sets. We started with a series of historical extracts of the California voter registration database. This formed the backbone of the cohort. And to those voter registration records, we linked statewide mortality data and those DROS records on gun transfers I mentioned a moment ago. So the fully joined up cohort consists of 28.6 million adults, essentially all unique registered voters in California between 2004 and 2017. It's at this point that I probably should pause and thank many of you for your participation. Cohort members are followed for an average of 7 years and up to 12 years. 1.2 million cohort members purchase a handgun or multiple handguns during the study period. 1.7 million die, and nearly 14,000 die from firearm-related injuries while we follow them. Here's a breakdown of those firearm-related deaths in our cohort. About 97% of all gun deaths we see in our cohort are either suicides or homicides, and that's very consistent with national statistics that Julie was showing a few moments ago. And on every cohort member, we have a bunch of information. So imagine the longitudinal structure of the cohort as looking something like this. As cohort members move through time, we observe who buys guns and who dies. Now, our main analytical approach is going to involve comparing rates of gun death during the exposed periods, which are represented by the green there, to rates of gun death during the unexposed periods, which are represented in red. That comparison is going to give us the estimate of the risks or the benefits of firearm ownership. Building this cohort was a massive data linkage effort. It took us the better part of 5 years, but once we had it, we could start doing some pretty cool things. Our first major analysis involved comparing rates of suicide over time among people who did and didn't buy firearms. The results were published in the New England Journal in mid-2020, and here's an excerpt from that paper. You're looking at adjusted survival curves here. The x-axis is time. The y-axis is the percentage of people still alive. The dotted line up top indicates firearm suicide risk among people who didn't buy handguns. And the solid line below indicates firearm suicide risk among those who did buy firearms. And for the buyers, the starting point, the time 0 there, is the first day they purchased their first handgun since 1985. You can see that that survival curve below for the buyers just moves away from the unexposed at essentially every moment of follow-up. And to summarize the risks over time, men who purchased had 8-fold higher rates of firearm suicide than men who didn't, and women who purchased had 35-fold higher rates of firearm suicide than women who didn't. Using an individual level cohort like this is a pretty respectable way to study suicide, but it's not a particularly effective way to study homicide. let's return to that cohort picture and consider these three people. None of them own guns while they're under observation. But what if two of them were married to gun owners? We probably want to think about their risk somewhat differently than the person who always resided alone in a gun-free home. I'm really just talking here about the difference between conceiving of risks and benefits as a household level phenomenon as opposed to an individual level phenomenon. To study homicide properly, we knew that we needed to construct households and look at the risk that way. And that was a tough assignment because tracking households in a large population like this is really, really difficult. And the problem is that people just won't stay still. So household composition changes through time as couples form and split. Teens head off to college, grandparents and lodgers come and go. And any one of those entrants or exiters could be a gun owner, which makes keeping track of our household exposure a really tough assignment. So that's been our major focus over the last couple of years, is to convert this individual level cohort into one that allows us to observe households longitudinally while at the same time following the guns. So with that background on the construction and design of the cohort, let me turn to our recent study of homicide. As Julie mentioned, there were nearly 25,000 homicides in the United States in 2020. 18% of them involved guns. Sorry, 80% of them involved gunshot wounds. And that 25,000 figure is a big increase over prior years. It was driven essentially entirely by a jump in firearm homicides, about a 35% jump in firearm homicides. We're still waiting on the official mortality statistics from last year, but many major cities have been reporting higher rates of homicide in 21 and 22, so the counts are expected to rise even further. For context, about half of all homicides occur in or around the victim's home. Nearly 1/3 of adults own guns, and about 10% of American adults don't own guns but live with a gun owner. That's the population I mentioned earlier. Personal protection is the leading reason gun buyers and gun owners report for owning weapons, especially for owning handguns. More than 70% of gun buyers say that the reason they buy a gun is to protect self, family, or property. There's a jarring discrepancy here between the prevalence of those security concerns and the weight of existing empirical evidence. The evidence suggests that a gun in the home is associated with higher, not lower rates of homicide. But as I mentioned earlier, those studies haven't really honed in specifically on the risks to non-owners. So that was our goal. And this was the study question. So drawing on that household cohort I mentioned a few minutes ago, we placed 821,000 non-owners in homes with guns, and we wanted to compare their risk of dying by homicide with that of about 19 million non-owners who lived in gun-free homes. Here are some descriptive statistics on the two groups. Time is short here, so let me just draw your eye to one pair of numbers. It's the gender breakdown in our group of interest, folks who lived with gun owners. And in that group, women outnumber men 2-to-1. So I want to repeat this point made earlier because it's a really important point. Most adults who live with gun owners but don't own guns are female. There were just under 2,300 homicides in our study sample. 1,500 of them were firearm homicides. Half of these homicides occurred away from the victim's home, and about 38%, the ones we were particularly interested in, occurred at the victim's home. And among those that occurred at the victim's home, 16% were perpetrated by a stranger to the victim, 27% were spouses or intimate partners of the victim, 34% were either family members or friends, and the rest didn't have a relationship between perpetrator and victim that could be determined. So turning now to the main results, I'm going to show some adjusted hazard ratios here, and the hazard ratios are adjusted for age, sex, race, and location. So we're really, as with all of the studies in the Long Shot project, we're only going to be comparing people who live in the same small neighborhood with each other. Gun owners, non-gun owners, people living in houses with guns, people who live in houses without guns. People living with handgun owners had more than double the risk of dying by homicide. And as you can see here, when you break down that risk, it's driven primarily by higher rates of firearm homicide. When we separate homicides that occur at the victim's home from those that occur outside the home, we see higher rates across the board for people living with handgun owners. But the largest relative rates are for homicide at home, particularly firearm homicides at home. People living with handgun owners were fatally shot at 4.4 times the rate of people in gun-free homes. Finally, when we look among homicides at home and focus on the different types of victim-perpetrator relationships, we again see higher rates of homicide for cohabitants of handgun owners. And this occurs in every relationship category, whether it's homicide at the hands of spouses and intimate partners, homicides perpetrated by family members and friends, or homicides at the hands of strangers. The elevated risk of intimate partner homicides are particularly striking. Rates of intimate partner homicides are more than fourfold higher for people living with handgun owners. And again, that elevated risk is driven almost entirely by higher rates of homicide. To that troubling result, let me add an even more depressing footnote. 84% of the victims in these intimate partner deaths were women. So some key findings from this particular study. Cohabitants of handgun owners are twice as likely to die by homicide as neighbors living in handgun-free homes. That risk is driven by higher rates of firearm homicide, not by rates of homicide by other means. The rates for homicide at home at the hands of spouses and intimate partners are particularly high, and the vast majority of those victims are women. There's a small minority of homicides perpetrated by strangers, usually intruders to the home. But importantly, they're also more, not less common among people who live with handgun owners. And we can perhaps talk in Q&A about why that might be. So our conclusions are that a gun in the home is associated with higher, not lower, risk of fatal assault, and that women are disproportionately affected. This really conflicts with the narrative promulgated by gun rights groups, and also the perception that millions of buyers have when they bring a gun into the home. And finally, I just end by saying the secondhand risks we estimated are really quite large in epidemiological terms. They're twice the risk of lung cancer. This is a relative risk statement, not an absolute risk statement. But when you look at sort of meta-analyses comparing the risk of lung cancer among spouses of smokers to those among non-smoking spouses of non-smokers, we're looking at adjusted hazard ratios that are about twice as large as those. So let me stop there and hand back to you, Julie.
Thank you so much, Professor Studdert. That was really great. And I'm sure there'll be lots of questions at the end. And now we're going to go to our second speaker, Amy Barnhorst. Let me just pull up my slide here. Dr. Barnhorst went to UC for UC Davis for med school and residency and stayed on there for faculty. She's the vice chair. She was a psychiatry resident and is a psychiatrist. She's the vice chair for community mental health at UC Davis in the Department of Psychiatry and the director of the Bullet Points Project, which in my mind is one of the greatest names of a project and most appropriate names of any project I've heard of, which is a state-funded effort to develop firearm violence prevention curricula for healthcare providers. In her clinical work, she treats patients with serious mental illness in the emergency department, the county jail, and a crisis unit, and a 50-bed inpatient psychiatric hospital. She's a nationally recognized expert on firearms law and mental illness, and works on the interface between firearms law and mental illness. Today, she's going to talk about her work on how we as clinicians can make an impact on firearms injury prevention. So thank you very much for coming, Amy.
Thanks, Julie. And I'm so glad that you like our name. You wouldn't believe the amount of time we went back and forth and asked people and spent thinking about that. So it's good to know it was worth it. As Julie said, so I direct the Bullet Points Project, and this is a state-funded effort to teach clinicians like you and other healthcare providers, including mental health care providers like psychologists and social workers, how to assess the risk and address the risk of firearm injury and death in their patients. If there's one thing you take away from my brief talk today, it's that this resource is out there and you can access it when you have questions about patient risk, what kind of interventions are available to you, and other things that you want to know. So I'll walk through today one of the frameworks we use in clinical encounters. It's called the 3 A's. And then at the end, I'll show you some resources where you can get more information about this. So the 3 A's is kind of our mnemonic of how to think about firearm injury prevention in the clinical setting. And it involves the approach, the assessment, and then acting. So I'll walk through each of these with some of the components of them. The approach to this clinical situation includes being informed, being respectful, keeping a harm reduction focus, and making sure that your recommendations or your actions are individualized and tailored for each patient's situation. It's important to say right off the bat that there are no state or federal statutes that prohibit us from talking with our patients about firearms and their access to firearms. This was from a court case that happened in Florida a long time ago. Well, 6 or 7 years ago, which is a long time ago now. And it's a myth that persists, but it is legal for you to ask. It is legal for you to document. It is legal for you to have these discussions. And for the most part, when surveyed, patients are also supportive. So majority of patients report that they think that conversations about firearm safety are appropriate with a healthcare provider. And a little more than half of gun owning respondents say that they think it's appropriate. That's just in general. When we add that there's a risk for somebody in the home, a risk of suicide or unintentional injury, 90% of people say that they think it's appropriate for thoughts of suicide, and 84% say it's okay when children or teens are in the home, which is a lot of households in the US. So generally, there may be some folks who are resistant to these conversations, but gun owners and non-gun owners are generally supportive. So in terms of the approach, part of being informed, and part of being informed is being here today and learning from Dr. Studdard and others about what information we have about firearm injury prevention. It's important to have a sense of who owns guns and why, and be aware of your implicit biases about what types of patients might be at risk and who might not. There is a stereotype of the older white rural male being the firearm owner in the United States, and certainly that is demographically supported to some degree. However, we know that especially during the COVID pandemic, a lot of people became first-time gun owners, and the demographics of ownership are changing rapidly, particularly including more people of color, more people who identify as liberal, more LGBTQ people, and more women. Using appropriate language, and we'll talk about that one a little bit more in a minute, but this shows that you know a bit about firearms, firearm culture, firearm storage, knowing the safest way to store guns, and we'll go over that briefly as well. And particularly being aware of relevant policies in your area, because when we talk about some of the actions and interventions that you can enact for patients who are at risk, it's important to know what you can do. You all are, I presume, practicing in California, and the Bullet Points Project is funded by the state, so we're focused on California stuff, but we're aware that some of the things we do here may not be available if you're in a different state. And then being able to assess risk, and not just risk in general, but who in the household is at risk. And Dr. Studdard talked about this, that it's not just the firearm owner, it's other people in their circle and what type of injury they might be at risk of. Second, it's important to have these conversations in a respectful way and take a harm reduction approach. So recognizing that, throwing data at people about the secondary risks of firearm ownership in a clinical setting where you have a brief encounter is probably, unfortunately, not likely to be terribly persuasive. And many people have a very strong connection to their firearms because it's how they perceive that they're protecting themselves and their family. So it's important to respect that if you really want to reduce the risk of injury, and take a harm reduction approach in the sense that a small step is better than no step. Remember that 1 in 3 households in the US has firearms in them. And it's important to keep your personal politics about guns, whatever they may be, out of the conversation if you want to make a connection and some progress. And make acceptable, tailored recommendations based on the situation of the household and of the family. Put things in the context of risk and safety, the same way we talk about other household risks, like smoking, like swimming pools, rather than right or wrong or good or bad. Some tips on language. We've gone back and forth on a lot of things, and reducing access seems to be a neutral way to talk about limiting people's access to their firearms in times of crisis. This is as opposed to things like restricting, revoking, rescinding. Anything that sounds like taking away Second Amendment rights generally tends to not go over terribly well. We also, if possible, encourage people to emphasize the temporary and voluntary aspects of some of the interventions. Some of these interventions are not actually voluntary, but if possible, it's great to be able to work with your patient and come up with a collaborative, temporary, voluntary approach, and emphasize that these crises often do pass and then their firearms can be returned. And make your approach individualized, again, tailored to who's at risk, who's in the home, and what type of risk exists. And some of this may have to do with people's reasons for ownership, what sorts of change they're willing to make based on whether or not they own their firearms for hunting, self-protection, other sport shooting. Here's an example of a good approach. So talking to a patient, really normalizing these conversations. I ask caregivers about all things that pose a risk to their families: water heaters, pools, medications, firearms. What steps do you take to reduce access to firearms for those who shouldn't have it? Obviously, in this case, referring to her small child. And making the assumption, as it's true for many firearm owners, that they are responsible and informed owners, and that they are taking steps to keep themselves and their family as safe as possible. The second A is assess. So when we developed this project, we went back and forth a lot about whether we were in favor of universal screening for firearms access in the clinical setting. And we overwhelmingly and persistently came down on no. I am also, a clinician in practice who has to go through a lot of different checklists depending on where I'm working and kind of the mandatory screening things we have to do. And it's a lot. And I also know from experience that the more checklists you have to fill out, kind of the less seriously you take them and the less your heart is in them. So I think it's more effective to have people really think about who is at risk of firearm injury and ask those people in a more meaningful way, rather than kind of a quick screening. Do you have guns in the home? Do you smoke? Do you exercise? Blah, blah, blah. So if you have somebody who's like a 30-year-old woman who lives alone, does not have children, doesn't have a partner who comes and goes, keeps her gun safely, or we don't know if she has a gun. It may not be, she may not have risk factors like depression or problematic alcohol use that merit asking about access to firearms. But if there's a child in the home, or if she lives with an older parent or has a history of suicide attempts, then it may be more relevant. So we'll talk a little bit about what some of the risk factors are. There's a few categories of risk. One is certain demographic groups. So as Dr. Parsonet mentioned earlier, the high demographic group for homicide by firearm is younger Black males. For suicide by firearm, it's older white males. We're not necessarily going to target people based exclusively on demographic group, but sometimes it's helpful to take into account what groups are at higher risk. And then there's individual risk factors. And we'll go through these a little more in detail: prior suicide ideation, violence, substance use, mental illness, dementia, and the presence of an abusive partner in the home. And then the third category of risk is ideation or threats. So regardless of whether or not somebody has other risk factors, if they're saying, I'm going to do this thing, consider that a risk factor. A little bit about the details of these risk factors, and this is a synopsis of various research, but most firearm suicides, as well as most mass shootings by teenagers, happen with a family member's gun. So these kids are not going out and purchasing firearms on their own. They're not stealing them or getting them off the black market or in straw purchases. They're taking them from the house, and that means those firearms were accessible to them. They have access to firearms in the home much more often than their caregivers think. There's some kind of terrifying, frankly, research about where they've asked parents, does your kid have access to the gun? They know where it's stored, and the parents overwhelmingly say, no way. And the kids say, oh yeah, I take that gun out and handle it. And only a third of firearm owners who live with teens store all of their guns in the safest way. So that means that 2/3 of them, these children and teenagers in homes with guns, have a firearm that is not stored in the safest way. And about 7% of US children live in a home with a unlocked firearm. Alcohol is another risk factor for both firearm suicide and firearm violence. One study found that a third of people who completed suicide tested positive for alcohol, and that those who used a firearm were more likely to be intoxicated at the time of their death. So there's not only an association with alcohol and suicide, but with alcohol and firearm suicide. Alcohol-related convictions are also a strong predictor of future violence. And this is to the degree that a number of states have actually considered legislation where multiple alcohol-related offenses, even if misdemeanors and DUIs, that those would actually incur a state-level prohibition. Dementia can pose a risk factor for firearm violence as well as firearm suicide. A small study in the South found that between 35 and 60% of people with dementia live in homes with firearms. And this can put other folks in the family and the household at risk, as well as the person with dementia. So there's a bump in the suicide risk early in diagnosis with dementia, and that is a high risk time where these folks should maybe not have access to lethal means. And as dementia progresses, people can often become paranoid, they can lose touch with reality, they can become confused, and they can have increasing agitation and irritability. These things can all combine together to put other folks in the home at risk of injury or homicide. And one way to approach these conversations, just as we approach the conversations with children in the home with the corollary of water heaters, swimming pools, etc., is to approach the conversation about gun access the way that we do about car keys. So maybe initially they can keep the access, then it's more supervised access, and that supervision increases and increases. Intimate partner violence and firearms. This is something that Dr. Studdard covered a bit, but about 50% of female homicides are committed by the intimate partner. And when that abusive partner has access to a gun, the risk of a victim's death in an abusive situation goes up by a factor of 5. Firearms have a really important role in intimate partner violence as well as female homicide, but they're also used to coerce, threaten, and terrorize and control women in these kinds of relationships. Also important to remember that domestic violence is a precipitating factor for many mass shootings. In fact, many mass shootings themselves are domestic violence incidents. They just don't get reported on quite as such unless they go out into a public arena. But often the ones that do take place in the public arena started out within the home. And here's the embarrassing slide where I now try to summarize the excellent work of the previous presenter with a little cartoon slide. But Dr. Studdard talked about how having a firearm in the home actually increases the homicide rate of other cohabitants, particularly for women and their homicide rates by an intimate partner in the home. And there is no protective effect against homicide by strangers in the home. So this is a bit, it's a bit at odds with our approach that we should only ask folks if they have access to firearm, if they have risk factors, because in somewhat circular reasoning, apparently having a firearm is in fact a risk factor. So that is a question that you can grapple with on your own, whether or not you think you should find out if there's a firearm in the home to determine there's a risk factor or the converse. I do think that there is a place for clinicians to bring up the fact that having a firearm in the home makes everybody less, not more safe. However, I think you need to be prepared that it is really hard to convince people of that if there's not the belief that they already have and the belief that they were raised with and sold by the media. Here is an example of what you're going to assess next, which is once you determine someone's at risk, do they have access to a gun? And then are they willing and able to collaborate in reducing their own risk? So I'm talking to an older suicidal man here, and I say lots of patients I see have guns at home, normalizing the conversation. And sometimes when they're going through a hard time, they store them out of the home. It's temporary, again, reinforcing that, and voluntary. And is this something you'd be willing to consider? If he's willing to take his firearms out of the home, that means that perhaps I don't need to go to a higher level of intervention. And we'll talk about what those interventions are right now under ACT. So we've arranged these from low acuity and sort of more voluntary to up in the red, the higher acuity and the less voluntary. These are 4 of the actions you can take. There are some others available on our website, but these are kind of the ones that we made a synopsis of. If no one in the home is at imminent risk, so you don't have somebody threatening suicide or that you're concerned has, advanced dementia or is, posting things about school shootings, safe storage is always an appropriate recommendation. And the safest way to store a firearm is unloaded, locked up using a locking device, separate from the ammunition, and this part is really important, with the keys and combinations inaccessible to children and others at risk. So oftentimes teenagers in the home will know the combination or know where the keys are. That's not really considered safe. Storage devices vary, and it matters what kinds of guns you have, how many guns you have, and what you want to use them for. So lock boxes are a really common option. These are small, they're portable. The converse of portable also means they're potentially stealable. But people can have these in their cars as well as in their homes. And one of the advantages of lock boxes is that they come with some, the fancier ones come with biometric technology where you can use a fingerprint to open them very quickly. So this is a great sell for somebody who says, well, I need to keep my firearm loaded because I use it for self-protection. I live in a dangerous neighborhood and I want to protect myself and my family. The non-harm reduction approach might say, listen, sir, you need to get that gun out of the home because you're endangering everybody. A harm reduction approach would be, hey, how about considering a biometric lockbox that you can keep, on your nightstand, in your desk drawer, wherever, but it's very readily accessible should somebody come into the home, while keeping it out of the hands of, your teenager and your toddler. Gun safes are sort of a larger version of that, but these can hold a lot more guns. They're better for long guns, and many of these can be bolted down or actually built into rooms like the one on the right so that they can't be stolen and pose a risk of theft. Two of the much smaller and less expensive interventions that are often given out free at gun stores and hospitals and law enforcement agencies are cable locks and trigger locks that actually either run through the magazine, the chamber, or they block the trigger from being pulled. And these are just ways not to keep somebody from, for example, taking or handling your gun, but from firing it. If anyone has a higher risk than just somebody in the home they don't want to have access to the gun, particularly in cases of suicide, it's important to remember that one of the most effective things you can do is put time and distance between that person and lethal means. And people do not tend to substitute with a less lethal means if you remove, say, the firearm from the situation. So one way to do this is via temporary transfer of firearms. So you can convince someone, as I was talking to the man in the picture before, about removing firearms from the home and handing them over to another person. In California, you're able to do this without a background check to a friend under certain situations. This is one of those policies you should check in your area. And sometimes people at gun ranges or gun shops or law enforcement agencies will actually hold them for you. In higher risk situations, there may need to be an emergency intervention and possibly an involuntary intervention to reduce harm. If the person is suicidal or potentially violent because of a psychiatric issue, you could consider a mental health hold of 5150. And if they're not willing to relinquish their firearms, but there is high risk, you can consider an extreme risk protection order, also called a gun violence restraining order here in California, for temporary involuntary removal of guns. These two things are not mutually exclusive. So oftentimes people think like, oh, we'll put them on a mental health hold and problem solved, we're done. That doesn't necessarily reduce their ability to purchase firearms in the future, nor does it necessarily do anything about guns they might have. So you can put someone on hold for dangerousness, and this is a great way to get them to psychiatric treatment. There are some firearm removal procedures built into this, and I won't go into detail, but they are not a surefire way to remove that person's access to guns if you're concerned. So gun violence restraining orders, this is California's red flag law. These are a way to pointedly target their access to guns. And they allow here in California a family member or police, and most recently we've added school officials and employers as petitioners to remove somebody's firearms based on a concern for violence or suicide in the near future. There's no criminal activity required, no mental health activity required. All that's required is that this person is perceived to be a substantial threat of serious harm. It's a civil order, and it's modeled closely after domestic violence restraining orders, where there's an emergency order that in the blue box law enforcement can get from a judge by phone. And there's also an ex parte order that family or law enforcement, or this is where the school officials also can petition. And if the judge deems that there is enough evidence just in the ex parte or emergency order, at which point the respondent hasn't had any input, they will issue an emergency order for the firearms to be removed and a prohibition to go in place. Due process is protected, so there is a hearing within a few weeks and the respondent gets a chance to try to convince the judge that they are in fact safe and should have their guns back and the prohibition removed. If they're unsuccessful, then the order can be continued after the hearing for a series of continuances and a variety of durations. So as a note, clinicians cannot petition directly for these, but we are able to work with law enforcement or family members to petition. I know I'm out of time, so I'll quickly say that, again, if you learn one thing from this presentation, it's that this resource exists. Mostly it exists on our website at bulletpointsproject.org if you have more questions about firearm injury prevention in the clinical setting. And you can also follow us on Twitter, and you can join our mailing list, which is right here. And we just launched our 1-hour continuing education course, for which you can get one PRA CME credit. And it will be online, advertised both on it, will be on our Twitter and also on our website. And it's an interactive video vignette course about firearm injury prevention for clinicians. So thank you very much. And thanks everyone for coming out for this really important topic.
So thank you so much. I'm just going to share my screen one last time. And I want to just mention before we get to the questions that Stanford also has a physicians and firearms curriculum that's online that you can get CME credit for starting probably next week. And it was put together by two of our SAFE leads, Christina Cantwell, who is at UC Irvine, Dennis Ketel-Tepe, who's at UMass, and then by me and Dean with the help of Amy here. And it has 3 modules on firearm injuries, on what the epidemiology of firearms. The second one is about firearms themselves, so you can learn how firearms work, what types there are, and the ammunition and gun locks. And the last one is on physician actions, and it does have a lot of links to bullet points, so it will help you navigate to Amy's site as well. And we hope people will share it with students and other people who you think would like to learn more about gun violence injury prevention. So we do have a few questions, and that I will try to bring in here. So I'm going to ask the first one. For Professor Studdert, is there any threat to California's laws with the new Supreme Court rulings? And do you think there are going to be things that are changed here due to those that recent ruling?
Yeah, great question, Julie. The short answer is yes, there are going to be changes. Julie's referring to the Bruin decision that was handed down on June 23rd by the United States Supreme Court. This was a decision that essentially overturned New York's quite restrictive approach to issuing right to carry permits in that state. And Justice Thomas, joined by the other conservative judges on the court, decided that under the Second and 14th Amendments, using a very originalist reading of the Constitution, those laws were constitutionally impermissible. There are 7 other states that have laws that look like that, so-called may-issue laws that gives the state discretion as to whether people can have permits to carry their guns outside the home. California is one of them, along with Connecticut, Massachusetts, District of Columbia, and others. So what's going to happen? California is going to have to rewrite its law. The Supreme Court has the final say in these matters, and how that is going to be done is the subject of considerable maneuvering in Sacramento right now. I think what we're going to see is that they are going to have to change the may issue standard that they have, but they are going to try to insert a number of limitations. So one would be that licenses can't be granted to people who have mental illness or are a danger to themselves or others. Another, and I think this is going to be a really interesting area to watch, is that there is going to be a prohibition on carrying in sensitive, so-called sensitive spaces. There was some room for that in the Thomas decision. That might include hospitals, schools, playgrounds, and other places of worship. So I think this is going to play out over several years as to what the new laws look like in these 7 states. And I think watch out for litigation around what counts as sensitive places. That may well go back up to the Supreme Court.
All right. Thank you very much. We have a question. I think, Amy, this one's for you, from Steve Ash. And he says he sees patients at the VA, and veterans have high rates of gun ownership and training, and leveraging their veteran identity has been effective in promoting household gun safety and harm reduction. And he's wondering if there are other identities like churches and PTAs, things like that, that you might be able to leverage to reduce gun injuries.
Yeah, absolutely. And this is, the VA has been a really, I mean, they've made great forward strides in this by exactly that. They have very high rates of gun ownership, very specific identities to the patient population, and really high rates of firearm suicide. So one of the things that we're working on, actually, our Bullet Points team is forming a coalition of firearm owners. So people who are leaders in the sort of firearm culture, who run shooting clubs, who own ranges, who are firearm safety instructors. And we're putting together a group of them so that they can help us inform with our suicide prevention education materials, practices, policies, because there's often been this divide between, you know, the so-called gun control advocates, and I'm with Julie there, where, you know, that's sort of a fraught term, but then the people who own firearms. And polling shows that we all want the same thing. We support universal background checks, we want safety, but there's a political divide, and firearm owners often feel stigmatized in those conversations and don't feel like their voices are being heard. So I don't know about other specific groups like churches or PTAs, unless they were a very high firearm owning group, but we are trying to build some bridges there so that we can, you know, center the voices of the people who are most affected by this.
So thank you so much, David and Amy. This is a really great Grand Rounds, and I'm so sorry that we don't have any more time for questions right now, but I'm sure both of our visiting speakers would be happy to get questions online if you have them. Just don't forget, next week, Grand Rounds is going to be in person, which I'm really looking forward to. So thank you very much for being here today, and we look forward to seeing you all next week.